be really grateful if you could interact once we've presented the papers, ask questions that you're keen to have discussed. The audience will be muted, however, so if you could put your questions in to the Q&A box, and then the chairs will work through the questions at the end of the presentations. We've got an hour and 2 papers to go through, so a maximum of half an hour per paper, and then we should all be able to get away by 8. So our speakers this evening said they're all from the Wrightington Upper Limb Unit. We have 2 consultant chairs, so Professor Adam Watts and Andrew Wright, and an AHP chair who's Ben Hughes, and then we've got 2 presenting fellows. Yusuf Atwan will be presenting tennis elbow paper, and then we'll have Thomas Clifton presenting the elbow revision paper. So I'll hand over to them without further ado.
Thanks very much, Fiona. We're going to start off with the tennis elbow paper that I hope everyone's had an opportunity to read. And Yusuf will introduce himself, tell us a bit about himself, and then we'll go through the paper. Thanks, Yusuf.
Thanks, Professor. So my name is Yusuf Atwan. I'm originally from Canada. Had the great privilege of being here in the UK at Wrightington Hospital and training under the panel here over the course of the year. So this paper that we'll be presenting is the tennis elbow paper, and I'll pull up. So it's titled "Persistent Tennis Elbow Symptoms Have Little Prognostic Value." It's a systematic review and a meta-analysis in the Clinical Orthopedics and Related Research Journal. It was published in 2022, and the authors are multinational. So as a bit of a background about tennis elbow or lateral epicondylitis, it's a painful tendinopathy of the extensor tendons, and it can occur in up to 3% of the population between the ages of 40 and 55. It's been long considered to be a self-limiting condition, but unfortunately there are a number of patients that suffer with this for an extended period of time, and that's why it's a hot topic to be studied. And there are people who have persistent symptoms where other treatment modalities that include surgery or injections or other forms of treatment are offered to them. So the purpose of this study was to look at the natural course of tennis elbow. So the study took a look at participants who did not receive any active treatment with tennis elbow, and took a look at their course of global improvement, as well as their pain, their disability in terms of their patient-reported outcome measures, as well as took a look at the symptom duration, or whether or not they had a placebo in the trials, and if that changed their symptom trajectory over time. So this systematic review and meta-analysis included randomized control trials of patients that had tennis elbow symptoms. And they included studies that had a non-active treatment arm. And what that meant was one of the groups received no treatment, which means either a wait and see protocol or non-specific exercises. They were just told to do some exercises for their tennis elbow, over-the-counter medications, or an information pamphlet, or in some studies, they were placed in a placebo or a sham treatment arm. They required the studies to have a minimum of 6 months of follow-up. And the study should have reported global improvement, and we'll define that shortly, as well as elbow pain intensity and disability. And as you know, when it comes to systematic reviews and meta-analyses, they have to put together a number of data points. And so various studies will report pain or disability in different forms. So what this study did is they prioritized pain in this order. So if a study reported pain with exertion, that was utilized rather than pain at rest, for example. And the same thing when it comes to disability, condition-specific patient-reported outcome measures were prioritized over other patient-reported outcome measures. And those were placed in a grading scale from 0 to 100 to put the data together. Treatment success, which will be mentioned in the results, it was defined as patients who had much improved or total recovery of their tennis elbow symptoms. And all the patients within those studies had their treatment success pooled within predefined time points. So at 3 months, 6 months, and 12 months of follow-up. And the study reported the proportion of patients who did not achieve treatment success at those time points. So overall, this is a consort diagram, which is used for systematic reviews and meta-analyses to identify how many studies were extracted from the analysis. So after all the screening that was done and the papers that were excluded as they were not eligible, 24 papers had remained, and that included over 1,000 patients in these randomized control trials that had an arm of patients who did not receive active treatment. Furthermore, there were 3 outlier studies, which we'll discuss later on, that were removed from the analysis because the results were significant outliers. And so overall, there were 877 patients that were included in the analysis. In terms of results, so the first one was global improvement, as we defined earlier. There were 5 trials out of these 24 studies that reported global improvement. And so they had a total of 257 patients. And so what they found was that the half-life of the persistence of global symptoms was about 2.5 to 3 months. In other words, every 2.5 or 3 months, 50% of the patients had symptom improvement, and thereafter it would cut in half at 6 months later on. And so overall, at 12 months, 89% of patients were defined as treatment success. When it comes to pain, the half-life was 3 to 4 months. So again, every 3 to 4 months, 50% of the remaining patients had pain resolution and pain improvement, and 88% had resolution at 1 year. And when it comes to disability, it followed a similar trajectory. Every 3 to 4 months, half the patients had remained, and 85% had resolution from their baseline values at 1 year. Another important result from the study, they took a look at the different studies that had the control group either being a placebo or a no treatment intervention, and took a look at if this made a difference. And so up to 6 months, there was no difference in terms of pain or disability scores. And at 12 months, the placebo group had a slightly lower mean disability. So overall, this was a great, well-done systematic review and meta-analysis, and it followed the PRISMA guidelines, which is a great resource to read if putting together any systematic reviews. They provide you with a checklist of what is required for a systematic review and meta-analysis to be accepted. The study was also registered in the Prospero database, which started at the University of York. This is another great database that can store all the systematic reviews that are actively going on and avoid duplicates. They had 2 authors that independently extracted the data. So that found all the papers, found duplicates, and included and excluded the ones that were appropriate. And whenever there was an inconsistency, a 3rd author would resolve that. They also use a risk of bias tool to exclude the randomized control trials that had a high risk of bias. And the 3 biases that would be pertinent to this study would be selection bias. So if the patients that were in those randomized control trials were maybe not representative of the population as a whole. Performance bias. So if a study inadvertently introduced differences between the 2 groups, and attrition bias if one group had more patients lost to follow-up than others. Other discussion points of this was that they excluded 3 trials because they were outliers in terms of disability and pain outcomes. So they didn't follow the same pattern as all the other studies, and therefore they excluded them over time, and we can discuss that later on. And what they included in there was this value. It's a I squared, which is just a measure of heterogeneity of a study. And so if there's variance in a study, and basically the larger the number means that there's more heterogeneity. And so what happened was, if you see that the boxes in the red arrow are what the values would be had they included all the studies, which means they would be more dispersed and maybe the variables wouldn't show any difference. But when they excluded the 3 studies, they were able to show that pattern that they had with the half-lives. Again, another drawback or just an inherent drawback of assessing randomized controlled trials and values from randomized controlled trials is a Hawthorne effect. So the fact that patients know that they were being studied might influence their results, and maybe this isn't the same for patients that we see day to day in our clinics. And lastly, the study took a look at data up to 12 months. So it showed us that there is a trend towards improvement up until 12 months with the provided half-lives, but not necessarily beyond that. So we don't know if we can extrapolate beyond 12 months with this data. And lastly, this is a great article by the BEST group describing how to approach patients with tennis elbow that may present in your clinic. What are pathological signs that maybe don't resemble tennis elbow, and if it is tennis elbow, possible treatment modalities. So it's a highly recommended guideline to follow and available in shoulder and elbow. Thank you very much.
Thank you very much, Yusuf. So we'll bring in all the panelists at this point to contribute. But Yusuf, what's your view about the impact of this paper on your practice? How does it change your approach to managing patients with tennis elbow?
I think it's a great study that summarizes a large proportion of literature, and it provides us with important time points of when we should expect patients to be improving. It might shine a light on patients that are not improving at a lengthy period of time. So for example, if patients present to clinics early when their symptoms start, we can provide them with data and let them know that, at 3 months, maybe 50% of people will be doing much better. But then it also provides me with an understanding that if somebody still has persistent symptoms at 12 months or beyond, they're likely a significant outlier in this pathology. And so maybe these are the patients that require a different type of care.
Is it, yeah, so is it just different type of care, or do we also need to consider whether it is the correct diagnosis? Because there is a tendency to think that all lateral elbow pain is tennis elbow when other pathology can be present.
Absolutely, and that was actually a point that was mentioned in the paper, is that the way that they diagnosed tennis elbow in these trials varied. So that could be one drawback. So not everybody had imaging done, not saying that imaging is necessary, but it is possible that diagnoses can be missed if patients continue to have persistent symptoms.
And from a physiotherapy point of view, do you think this has been a helpful contribution?
Yeah, I think it's great for us. I think it's a really powerful study, and in terms of being able to be very frank with the patient about timeframes, that gives a lot of time for us to do our rehab and generate some buy-in and build rapport with the patient. So I think from a physio point of view, it's really useful being able to come out with that stat of 90% of people are going to improve over that 12-month period does set the scene, and it helps sort of manage that risk of somebody sort of feeling like they've maybe got a 12-week window or until their next clinic review to get better, and then you factor in waiting list times and a few cancelled appointments, and sometimes you can feel like you don't always have enough time to exhaust the rehab before further management options are discussed or people feel like they need to be discussed. So being able to use this and set the scene early is great. And I think certainly in our practice, we would want to give things a good number of months of optimized rehab before considering anything else. Anyway, this maybe just allows us a bit more peace of mind and extending that time frame a bit further down the track, if anything. So yeah, really, really useful.
Andy.
Thanks. I noted they did some subgroup analysis as part of the paper. Yusuf, I don't think presented it, but they one of their subgroup analysis showed that the duration of symptoms before trial in patients were enrolled in the trial had no association with their course of improvement. So even patients who'd had symptoms for 70 or so months prior to being enrolled in the trial still improved over that 3 or 4 month window. I wonder what the panel's views are on that, or how much we might be witnessing the Hawthorne effect in that. Yusuf, what do you think about that? And Ben, I'd be interested in your view as well.
That was my initial thought as well. The Hawthorne effect may be playing a role. It's just interesting that the duration of symptoms prior to enrollment in the study was really variable, yet they followed a consistent timeline after enrollment in the study. So it's very possible, but it's really hard to draw any conclusions from that beyond that.
Yeah, I think it's a really interesting point, Andy, and I note that they also had an age range that is fairly typical of lateral elbow tendinopathy group as well. So we can be fairly confident that this group are the sort of people that we're seeing in clinic. From a therapy point of view, I think sometimes we do see people that have had symptoms for a long time get better relatively quickly, and for any HPs or physios or therapists in general that are on the call, I think it just points at our need to spend time with the patient and really understand what their physical needs are going forward in the long term, and also where they're starting from. Are they particularly irritable, or are they not so irritable and therefore able to be loaded a little bit quicker? So I think we can sometimes assume it, long time of symptoms before having symptoms for a long time means that your recovery is going to be slower, but I don't think it always plays out. But it's an interesting point. You're right.
Yeah, I think I took that like you did, Ben. I found if anyone's been part of any RCTs or recruiting patients to an RCT, there's a huge amount of information you have to provide the patient with so they can make an informed decision to take part. And a lot of that will be educating the patient on their diagnosis, as well as the treatment options and the equipoise around those. So I think, as you said, Ben, I think that just plays a role in us educating patients who we see for the first time with tennis elbow about that their symptoms will be self-limited, what their condition involves, and hopefully we can provide that improvement that the trial patient has shown as well.
It's certainly my experience, Andy, is that this is actually a really empowering study for patients when you inform them about this study and the results of that they can understand that actually this is going to the likelihood this is going to get better. They don't have to have an active treatment. They don't have to have an intervention for the condition to get better, and very often that's the reassurance that they need from us, which undoubtedly is a good thing.
Yeah. I thought it was interesting in the discussion as well. The authors, who I think are mainly therapists, Ben, I don't know if you can correct me on that, but they stated sort of the most patients attending with prolonged tennis elbow symptoms proceed towards surgery. Now, I mean, Tom and Yusuf, you've obviously come from different countries. It'd be helpful to have your insight on that. But I think our practice at Wrightington is very few patients who we see presenting with lateral elbow pain proceed towards surgery. I can think in my sort of 5 years of maybe one. I don't know how many a year or every 3 years, Adam, you might operate on.
Yeah, very few require surgery in our experience. But Tom, I'd be interested to bring you in here for the Australian experience. Some of the authors were from Australia, but what's your experience with managing this from the Australian perspective?
Yeah, thanks, Prof. So certainly people have been waiting a long time before they get to your rooms in Australia as well in the public system, and have often trialed physiotherapy and injections, but we don't operate on them frequently. Certainly they would have had 1 or 2 target injections organised by our team first, and physiotherapy, and it's only if they fail that after a period of 3 to 6 months. But what's probably fascinating is what I would like to see is the difference between intervention in the public sector and intervention in the private sector, because I think people are more likely to probably have this operation in Australia in the private sector than they are in public for many reasons. But certainly throughout training, it's something that we saw very infrequently, maybe 1 or 2 in 5 years of training.
One of the things that I often hear from people is that, well, the patient wants me to do something. You know, they've come to me with pain and they want me to do something. And actually, you know, I think this study actually shows us that that's not necessarily the case, and that actually giving them information is the most important thing that we can do. The other thing that's, I think, really important is that we need to emphasize that it's a dynamic problem. So invariably, it wasn't just one sort of incident that sort of triggered the onset of tennis elbow. It's related to activities, and that they need to understand that if they persist with those activities that might have led to the development of the condition, then that's going to affect the natural history. And so giving them information and enabling them to understand, you know, what's led them down the path to pain actually can help them to resolve things without us needing to intervene, which has to be a good thing.
Can I just highlight to the participants, if you're frustrated with us not tackling the question you want to ask, or you want to hold Professor Watts's feet to the fire about his treatment of tennis elbow, please feel free to use the question and answer box, and we'll put your questions to any of the panel you wish.
Yeah. So, and I guess another question that stems from this is, people say, well, the role of surgery is for failed non-operative treatment. How do we define failure of non-operative treatment? Yusuf.
Based on the discussion that we've had and based on this meta-analysis, non-operative management can include no treatment at all, and not really, you know, this study lumped in a number of what we call non-operative measures or non-treatment measures, and so it's that's difficult to pinpoint what that would mean, because you can take it up a ladder and include injections beyond that. You can utilize active therapy, because the study didn't take a look at active therapy, for example. They took a look at non-active therapy. Maybe somebody was given generic exercises. So in my mind, beyond the study, I think the next step up would be to attempt some form of active physiotherapy. There are other injections that we can discuss their utility, and those would have to be exhausted before discussing surgical options. But I think the biggest point is something that you highlighted earlier, is just making sure that no other misdiagnosis is evident. So no evidence of instability or any other elbow pathology that could be labeled as tennis elbow. And I guess from a perspective, you know, coming from Canada, we have only a public sector. And the thing that I worry about is we do a lot of education for primary care providers, because there are a lot of people that have tennis elbow and not necessarily need to be seen by an orthopedic surgeon. But the biggest worry is maybe these patients that have persistent ones are labeled as tennis elbow, but actually have been suffering with something else over the course of the year. So I think those are the biggest things that come to mind.
Yeah, we've got a question that's come in, and I'll take that in just a moment. Just to raise one point about that actually is important as well to the results reported here, that there is only one randomized controlled trial of surgery versus placebo or sham, and that was included in this, and that's the Crosslack study, relatively small RCT. It's interesting that actually the placebo arm that was included as a placebo within this study is actually active surgery, because in the placebo arm, the patients had a surgery to the elbow where the the ECRL was incised, but they left the ECRB alone. I think it's quite hard to argue that that is truly a placebo in a setting. But Harvinder's asked a great question, which is, how do we respond to patients who've come asking for an injection? I assume, Harvinder, you mean steroid injection, as they responded to an injection when they had problems with the other side. Tom, I gave Yusuf a tough question, so I'm going to pass that one to you.
Yeah, thanks, Prof. Look, it's the difficult problem, I guess, going back onto the diagnosis, just because they have symptoms doesn't necessarily mean they've got bilateral. So careful history and examination. And then, sorry, was the question about having another injection on the same side or
no?
So
they had a good response to a steroid injection
elbow
on the contralateral side, and they've come to you saying, "I've got tennis elbow."
Yeah. So careful history and examination, of course. And then, look, I don't mind offering as long as I'm sure about the diagnosis, an injection as a part of their non-surgical treatment algorithm. But just because we got a good result from one side doesn't necessarily mean we'll get a good one from the other as well. That's the thing to mention. So it's about counselling the patient as well as a physiotherapy program. And what you mentioned, avoidance of activities that provoke the condition, they're all equally important. So it's not just a panacea or a steroid, it's an array of treatment. That would be my answer.
Thanks, Tom. Andy or Ben, do you want to add anything to that?
All I'd say is that I think the literature shows that a steroid injection can be beneficial in the first 6 weeks, but that benefit at 12 weeks is outdone by placebo in Bissett study and Coombs studies. And I think those are the studies that have put pay to recurrent corticosteroid injections. So it might be that in this sort of instance, you have a bit of a discussion with the patient around, well, there is some short-term benefit, we think, but that doesn't seem to last when we compare that to not having an injection or any other sort of active treatment, and try and give them the playing field. Because I guess you could end up down a road of recurrent, short-term injections, which I think would then we'd maybe be concerned about impact on tissues then. Well, certainly that's my understanding of that aspect of the literature.
Andy?
Oh yeah, I wonder if there's one more question I might put to you, Adam, if you don't mind, and then maybe perhaps I'll ask Ben one question and we move on to the next paper, if that sounds like a reasonable plan.
Yeah. So if I may just make a comment about the corticosteroids, because we do have to be Montgomery compliant, so we do have to make patients aware that steroid injection is a treatment option. But my experience, when you explain to them that there is a risk that they'll be worse off at 12 months, most patients choose not to have it. So, but yes, go on, Andy.
So the question submitted was, what surgery would be completed if surgery was the decision?
So again, it's joint decision making, and if a patient has reached the point where they're so fed up that they're prepared to consider going under the knife to resolve their pain, the evidence is that it doesn't matter what the recovery the same, but of course, and that's around 90%. But of course, what this study that we're discussing today has shown us is that actually it's really difficult to prove that it's the surgery that got them better, because you would expect that even the patients that you're listing for surgery will have a 50% chance of recovery over 3 months. So the surgical effect might be quite small. We just don't know. We just don't know the answer to that. But it would seem that whether you do offer arthroscopic or open surgery, whichever type of open surgery you do, the outcomes are pretty much the same. So I think there's probably a final common pathway, and we're just producing an inflammatory response, which then cures the problem.
And what would be your preference if you were pushed?
Well, I very much let the patients choose. I explain to them that I can do it keyhole and there's a quicker recovery, but there's a greater risk of nerve problems, or I can do it open and it'll take them longer to recover. But it's a slightly lower risk procedure, and it's very much their view of risks and impact on recovery, and let them choose.
So I think also the benefit of arthroscopic surgery, I suppose, in a counselling point of view, is that anything other pathology that you might find within the elbow that might attribute for their non-recovery of symptoms could be treated simultaneously, I suppose.
Yes, I mean, if you think that there's a coexistent plica syndrome, then I do tend to lead them down the arthroscopic route, because I think I can treat both pathologies simultaneously. We should move on.
Yeah.
That was a great discussion. Thanks very much, Yusuf. Thank you for that. And Tom, do you want to share your screen?
Yeah,
and we will change gear and think about infection.
So thanks, Prof. So I'm Tom Clifton. I'm fortunate to be a fellow at the moment as well with Yusuf at Wrightington Hospital. I'm from sunny Perth in Australia, and it's my pleasure to talk to you tonight about prosthetic joint infections of total elbow replacement. So the paper that we're looking at is a Mayo paper out of the Mayo in the US, looking at 2-stage reimplantation for deep infection after total elbow arthroplasty. With some well-known names there in the author group. So the background of this is that the incidence, unfortunately, of prosthetic joint infection in primary elbow replacement, total elbow replacement, is anywhere from 1 to 12%. And the treatment options are largely the same as the hip and knee literature, in that we can suppress patients with antibiotics if they're elderly or they're not fit for surgery. We can perform a debridement and implant retention, where we keep the implants but change the liners, and do a thorough soft tissue debridement in the hope that will cure the infection. Or we can do a single-stage revision or a 2-stage revision. Just for everyone in the audience, a single-stage revision is where we remove all the components and do a debridement in one sitting, and then put new components in at that very time in the operating theatre. Or a 2-stage, which is the gold standard across all large joint arthroplasty, although this is changing, is where we take out the components, do a debridement, put in some form of temporary articulation with antibiotics, and then come back after a period of antibiotic therapy and then do the definitive operation. And then finally, resection is when you remove everything. That's usually the end of a painful road. Persistent infection rates, however, in the elbow behave differently from the hip and knee, in that the hip and knee rate of persistent infection is 5 to 10%, and the elbow is up to 25 to 30. So clearly there's something different with this joint. So this paper itself was a retrospective case series of infections treated with a 2-stage revision at the Mayo Clinic. They had included a total of 52 elbows with a mean age of 61 for the patient. The primary diagnoses were primary traumatic osteoarthritis, or post-traumatic osteoarthritis, sorry, inflammatory primary osteoarthritis, and then trauma, which they divided as acute or subacute. Interestingly, 74% had undergone further surgeries after the primary, but before the first stage, which is, to me, indicative that obviously something is going wrong. And some of these operations that they'd had were periprosthetic fractures that needed to be fixed, revision for loose components which were not infected at the time, wound debridements or exchange of the polyethylene, the plastic liner, problems with triceps, problems with the ulnar nerve, and skin coverage problems. The way they diagnosed infection they used the MSIS criteria, which again is populated by the hip and knee literature, which is the presence of a sinus tract or fistula, or alternatively 2 or more positive cultures with the same microorganism in the same time frame, same sampling, which is preoperatively at the time of surgery. But interestingly, a high index of suspicion was held for elbows presenting with rapid unexpected loosening combined with pain and swelling and elevated CRP and ESR. Positive aspiration, as in bacteria, was isolated preoperatively on an aspirate in 71% of elbows, and loosening was present on radiographs in 86% of elbows. The organisms, which we'll come to later, are relevant in this discussion. The ones they cultured were Staph epidermidis, most commonly 54%, and then a range of others, Staph aureus, Cutibactum, etc. And we'll discuss why that's important shortly. And the treatment, so 2-stage, as I explained earlier. First stage, complete removal of components was only achieved in 83% of patients. So 17% of patients, they had a well-fixed component that either decided it was too destructive to get out or couldn't get out. And incomplete removal of cement was also present in 42% of patients, which they saw on post-op x-rays. And again, that's important, and we'll discuss that in the conclusion. Then they placed an antibiotic spacer, and then they did a minimum of 4 weeks of an interval with antibiotics until the 2nd stage, and then reimplanted in the 2nd stage. And the mean time between the index replacement and the 1st stage was 7 years. The results. So eradication was achieved in 69%. So negative cultures at the time of reimplantation and no additional surgeries for infection, I should say, were achieved in 69%. Interestingly, there was no difference in the rate of eradication between those patients that had a well-fixed component left in, as well as a debridement and changing of the other, and those that had complete resection. But they found that there was a 3.3 times higher risk of failure if you retain cement. And there was also a 3.5 times risk of failure with Staph epidermidis. So that bacteria in particular is obviously quite virulent when it comes to persistent infection. Interestingly, they found no difference in your BMI, in the age, in the gender, in the smoking status of patients. And also interesting to note, in the eradicated group, so patients that had their infection eradicated by this whole treatment algorithm, good or average Mayo elbow scores were only achieved in 60%. So really 40% of the patients that made it through this with no infection are unhappy. The authors postulated that the factors that lead to poor outcome with the elbow, unlike the hip and the knee, is that it's a poor soft tissue envelope, as in there's not much subcutaneous fat in the area or muscle to cover. Removal of well-fixed components and cement is difficult with a high complication rate. And so I thought this was interesting. Of the 32 patients that had their infection cleared by this 2-stage reimplantation, 14 of them went to have further surgery. This was in the form of either revising it because it was loose without infection, radial nerve palsies, ulnar nerve palsies, and triceps problems. So, almost half of the patients that made it through it without infection are still getting further problems. So on this, Prof and I were talking about this the other day in the theatre. Obviously, there's a lot of problems with revision elbow surgery, even when you cure the bacteria. So prevention is better than the cure. I had a look, a review at, what you can actually do preoperatively to try and minimize the chances. And a lot of the things that we do in medicine make sense, but they aren't evidence-based. So all of the decolonization protocols that we do don't have strong evidence. Delaying someone's surgery because they've had a steroid injection, which we were talking about earlier, doesn't actually have any evidence for it. Antibiotics impregnated cement or antibiotics sprinkled into the surgical wound doesn't have any evidence at this stage, and neither does putting betadine or chlorhexidine in the wound, but there is very strong evidence for preoperative antibiotics. Interestingly, and this was reinforced by this paper, obesity, diabetes, and inflammatory conditions are not significantly associated with periprosthetic elbow infection, which was some previous work by Maury, one of the authors. So to critique the paper, Prof Watts kindly directed me towards the JBI assessment tool. JBI is an international organisation which is quite helpful in critiquing and standardising research. And one of the key things they have is you can use this assessment tool to basically dissect the crux of the article and decide whether you think it was high quality evidence or not. So if we go through, I think this paper was well done. It was a retrospective case series, so already it's not as powerful as a randomized control trial or a meta-analysis, but it was a well done case series. There was clear inclusion and exclusion criteria. The condition was measured in a standard, reliable way, as far as I could tell, with valid methods. It wasn't clear whether they had consecutive inclusion of patients, as in whether they included all the patients in a row that had infections, but I imagine that was the case. And the demographics were reported well, clinical information was reported well. The outcomes and follow-up results were clearly reported, including all their complications, importantly. And the statistical analysis was appropriate. So overall, I thought it was a well-performed paper. But I'd love to hear the panel's thoughts and all your thoughts on it as well.
Great, Tom. Thanks very much. So yeah, that's great, and we'll bring in the whole panel. So we've included this study because it has been influential in my practice. But one of the things that you've highlighted here is that there seems to be a slight disconnect between the fact that if you've got retained cement, that's a problem. But if you leave an implant in, a well-fixed implant in, that doesn't seem to be a problem. Tom, what are your thoughts about that, and the possible reasons why that might be, that might have occurred in this study?
Yeah, good question. I was thinking about that because I thought you might ask me something like that. And I wonder whether there's enough power. I mean, they had 52 patients, but I wonder whether there's enough power to appropriately say whether that is truly the case, whether it's a significant result or not, because we're only talking about 52 patients over the a course of 10 years. It doesn't make any biological sense to me that if you retain titanium or cobalt chrome and cement, but and that's fine, but then you retain a few globules of cement in another patient and they have persistent infection. So I would rather refer it to a methodological problem rather than true science. But and I think it's not whether those patients, if everything gets removed, obviously they have further problems. They have osteotomy, poor bone quality, wound issues, but they've separated that because they've just looked at persistent infection. So I'm a bit confused as to that result as well.
It's possible, isn't it, that as you say, it's just a statistical quirk based on small numbers. It's a big series for infected elbows, but statistically, it's a very small sample. But you also wonder whether there may be a relationship between the infecting organism and loosening of just one prosthesis versus loosening of both prostheses, and actually whether that is a factor in the risk of recurrent infection. Because it's possible that if you have a more aggressive organism, difficult to eradicate, that it's going to loosen on both sides, and therefore you're going to end up taking both implants out. But it's hard to know based on what's been presented. As you say, prevention is definitely better than cure. And I think the biggest conclusion from this study is don't get involved in doing revision elbow arthroplasty because it's just miserable, isn't it? The overall complication rate is 50%. So if you think that every other patient you operate on is going to have a problem, it's fairly sobering.
Yeah, I felt that discussion section.
Does that keep you awake at night, Andy?
The discussion section where Joaquin is sort of highlighting the complications upon complications that can occur in revision elbow surgery at every stage is quite sobering, really, isn't it? As you said, the prevention's better than cure, and it's really important to highlight that 60% of those patients who were having their elbow replacement had trauma prior to that, so it was they're having essentially going ahead with elbow arthroplasty following trauma, and it's already emphasizes about all the steps that over the last sort of 20 years of improving our management of elbow trauma to try and prevent patients sort of heading down that pathway. I think is really a really important point to take away, I suppose. from this.
Does it though, Andy? Does it affect your decision making if somebody has post-traumatic arthritis and they have metalwork in? You're thinking about doing an elbow replacement. Do you have some special considerations in that situation?
Yeah, I mean, I think we ultimately try and do everything we can to remove metalwork, biopsy, you know, extend the number of stages, I suppose. Whether we're doing the patient any good by the results of this data, I don't know, you know, because even as Tom sort of finished off by saying, you know, it was around 65% of the whole, everyone had further surgery, you know, it's like, so it's really sort of a downward spiral. So it just goes back to some of the counselling points we put on the tennis elbow paper. I don't know if we are robust enough with how we counsel patients, and obviously it's difficult for them to hear when they've got terrible pain in an elbow which was normal before a traumatic event. But yeah, I think all we can do is what best for the patients, which involves you know, that preliminary stage of removing metalwork, a biopsy, having a strong MDT with microbiologists, and treating any signs of infection prior to implanting a definitive prosthesis.
Mm-hmm. We've had a good question. Yusuf, I'll direct this at you if I may. So the question is, it's interesting to find that the high BMI is not a risk factor. Would it be wrong to presume that a high BMI gives better soft tissue coverage and therefore you're less likely to have such complications? What are your thoughts about that?
I think it's an interesting thought and an interesting conclusion. I don't know if we can rely on the BMI from this study because, again, there's a small number of patients, and that doesn't give us a you know, a big cohort to conclude that result from, or where do we draw the cutoff of what beyond what BMI is related to it. I do think that having a better soft tissue envelope does provide, well, it's hypothesized to provide a better protection for against infection. In patients that have had, for example, triceps failure, that's another layer that's gone, and you just have the skin, and they're a higher risk for an infection. So I think it's an interesting idea, but I don't know if I can be definitive about BMI not relating to infection based on a cohort of 50-something patients.
Yeah, as you know, Yusuf, I'm a little bit cynical about the argument about the thickness of the soft tissue cover being a reason that we get more infections in elbows, because actually most elbow wounds, in my experience, heal pretty quickly and pretty well, and I'm not sure the bugs know how far they've got to go to reach the surface. But one thing that sort of that correlates between a poor soft tissue envelope and the risk of infection is, of course, the immunocompromised or frail patient. And that is a problem that we have, and in that over 50% of our patients are rheumatoid patients. And that surely has to be the biggest factor at play here, that our hip colleagues are not having to deal with, our knee colleagues are not having to deal with. It's a very different population that get elbow replacements compared to other joints. What are your thoughts on that?
Yeah, to be completely honest, I'm not 100% sure. And that's what's troubling about elbow arthroplasty. One anecdotal thing, which maybe I'll flip around and ask you, I've seen various types of, for example, stage 1 spacers that are used to treat infection. And some of them are more bulky than others. And those have caused compromise to the skin. If they're more bulky or protruding, depending on, for example, you know, an internal X-fix or equipment like that, and that has caused some compromise to the soft tissue. And so, if you're using that type of system and you don't have enough protection, then that's easy for it to protrude through the skin. but maybe that just depends on the type of implant that you're placing as an antibiotic spacer, or some that cause fractures and that protrudes and causes compromise to the skin. So I'm not sure if that plays a role. Maybe this patient population uses different types of equipment when they're trying to eradicate infection. That's the only thing that comes to my mind.
Mm. Yeah, you definitely want to try and use a benign spacer, don't you? Andy, look, you want to come in?
I was going to ask you something, Adam, because obviously, as you mentioned at the start, this paper has changed our practice in terms of being much more aggressive in trying to remove all the cement from a previous component. So we're much more likely to ulnar or humeral osteotomies to assure we clear all the cement. The other thing from the paper was showing a 3.5 times higher rate of reinfection with staph epidermis. I wonder what your feelings are on how we can, if we identify that bug, how we might manage that differently to try and get a different response.
I think one of the important lessons that we can learn from our lower limb colleagues is about a multidisciplinary approach. So having a microbiologist involved at every step of the way with revision elbow arthroplasty, so we're making the right decisions beforehand, making sure we're getting the right samples at the time of surgery, and that they're receiving those in a timely manner and able to process them in an appropriate way, and then following their advice post-op. But very often we will, if depending on the organism, particularly staph epidermidis and C. acnes, we will put them onto lifelong immunosuppression, antibiotic suppression, because you almost, well, it's really hard to eradicate those bugs. And so at Wrightington, we do, when we do a 2-stage revision, it's actually 3 operations, because of this very high rate of reinfection. We actually, before we do our 2nd stage implantation, we go in and take more open biopsies, even if the blood parameters are normal. And we have identified organisms at that that biopsy, which has then led to a further round of antibiotic treatment and debridement of the joint, and then has led to successful eradication. So we need to be very aware of the organism that we're treating, and the most difficult situation I think we find ourselves in is when a joint is clearly infected and we can't find the bug, because then we don't know our enemy, and that's a real challenge for us.
Yeah, I think Tom, you were mentioning today, when I think it was yourself saying that if you can't find the bug, you assume it to be C. acnes. Is that right? Is that sort of how you manage things in Australia?
I think that was Yusuf referring to shoulder at the Paris course.
But, yeah. Oh, okay.
Yeah.
We were discussing this today, weren't we? But I think that's a useful a rule, really. If you've got a high index of suspicion, if a joint's failing within the first few years of implantation, you've got clear lucency, I think you have to suspect an indolent infection, even if you don't culture it on your samples.
Absolutely.
Tom, we're coming to the end of our time. Just one other question, and this is probably a very unfair question, but we've used the MSIS criteria in this study, or the authors have. As you know, at Wrightington, we use the EBJIS criteria for diagnosing infection, which relies on a lot of other markers for infection, so leukocyte counts from the aspirate, and it also takes into account other things such as PCR. Do you think that maybe we need to have, do we need to have that breadth of investigation, or do you think a sinus and 2 organisms gives us the answer?
It's interesting you asked that, Prof, because I had a case the other week. It's a shoulder case, but there was a sinus, and the patient said there was pus coming out of my arm, and then the sinus closed over, and I said to the consultant, that's infected as per MSIS criteria. And he's like, well, actually, in my experience, it doesn't necessarily mean the whole of the arthroplasty is infected. It might just be the soft tissue around it, or superficial to it. And, that statement sort of went against everything that I've been learning for the exam and in practice. But I guess it makes sense. Just because there's a sinus tract or you have an aspiration of bacteria doesn't necessarily mean that the entire arthroplasty is infected, or in fact needs to all be removed, as we saw in that study. They're having good results with retained components. But I don't know enough to know whether all of those other parameters, I mean, I don't imagine there's been any study that compares MSIS to your applied criteria. But I think that's why they mentioned also they were highly suspicious with rapidly progressive loosening, pain, erythema, and blood tests as well. So they're not just looking at those two things blindly. They're also saying, well, we're highly suspicious with this, and then subsequently went to culture bacteria. So I think the take-home point is that it's not to be militant about those two things. It's also to look at the whole picture and be suspicious.
Absolutely. I think that's a good take-home message, and useful for our physiotherapy colleagues who might be seeing these patients in follow-up clinics. It's always better to ask the question and to raise your hand and say, look, I think there may be a problem here, than let the patient slip through who might be running into a problem.
Indeed.
So thank you very much, Tom, indeed, and to the whole of our panel. And I hope it's been useful for everybody watching at home. Fee, do you want to add anything at the end? I think you told everybody about future.
Yeah, no, thanks to
Journal
yourself
clubs.
and the rest of your team at Wrightington for giving up your evening. And also to Jo, who is hiding behind the British Elbow Society Square, but she's done a lot of organisation and sent lots of emails and been pretty pivotal in getting us off the ground, so thanks to her. The next timetable session is in May, so 22nd of May. Leicester are hosting that one, so we'll get the information from their team and get it circulated nice and early for anyone who'd like to join us then.
Thanks very much.